Welcome to Mental Health in Focus, brought to you by Flow Vector Systems. We're passionate technologists dedicated to helping businesses get started and thrive with AI integrated solutions. Find flow state in your business. Now let's move on with the podcast.
Good morning. It's great to see you again. I know it's been a couple of weeks since we spoke, and I think you were in Virginia last time we spoke.
Yeah.
Are you back in?
Yeah, still there.
Okay, still there. Okay.
Yeah.
All right. Well, great. Well, I'm here in Atascadero, California. Shaping up to be a nice day. So, yeah, hopefully I'll escape my office here at some point today and go out and enjoy some sun. Yeah, but Shannon, I was hoping you could just spend a couple minutes talking about yourself, talking about how you got into mental health care, and talk a bit about your practice, and then we can run from there.
Yeah. So I am a survivor of childhood trauma, starting at age 3 to about age 12, and then experienced an assault in college, which kind of just exacerbated all of that complex trauma, and started to self-medicate with alcohol and relationships. And eventually I ended up working in law enforcement because I thought if I had a badge and a gun, no one could hurt me anymore. But what I found were thousands and thousands of people suffering an addiction because of trauma. The poorest, the most intersectionalized, from abject poverty to complex trauma to, just horrific circumstances, self-medicating, and ending up in the criminal justice system because of those intersections, right? More policed areas, more likely to be criminalized as children when they're acting out in a school setting without adults that know how to show up for them the way school systems expect parents to show up for them. Yeah. So seeing in person the trauma to prison to early death pipeline, the exploitation of women and children and vulnerable people in that space, how the exploitation leads to more self-medicating addiction, and the revolving door of criminal justice, which is not trauma-informed and not healthcare focused, penalizes, criminalizes addiction, criminalizes disease, and people get stuck in those mires of abject poverty and those intersections. And so seeing that from the perspective of a survivor, I didn't want to criminalize people. I wanted to create programs. And so I did the last 12 years in law enforcement and corrections. I created gender responsive trauma-informed programs in the state of Utah for women and girls, worked with the JJS system. And then they would only let me go so far. They didn't want me to talk to the press. They didn't want me to talk about the amount of abuse occurring in the community and the amount of sexual abuse and the amount of sex offenders that we had in Utah, and that we were above the national average, and that was really pushing that underlying complex trauma addiction piece, right, in the community, that we weren't addressing the violence in the community. Still, you don't talk about it. Like Elizabeth Smart, I think just this week had national attention around, because she did, I think she did some fitness modeling and ended up on a national stage and is now being, interviewed by national groups and is talking about the violence in Utah. The amount of predatory behavior, and that leads to all these illnesses, right? All these complex intersections with illness, criminal justice system, poverty, all this stuff. So somebody like her can talk about it, but when I ever mentioned it, it was cut out, right, of the local news. So seeing that and learning the national evidence-based models, being able to teach it in other states, and then bringing that model to Utah, I retired at 20 years and created Journey of Hope, the nonprofit that I now work in, just to help people unwind trauma and heal from addictions and heal their brains and limbic systems so that they don't die 25 years early because they were abused as children. So really that holistic piece, but overwhelmed with the number of people that need these services, don't have enough funding to reach all of them. And so we're triaging. So we became the go-to domestic violence, sexual assault, human trafficking for people that were in that pipeline, right? That were in poverty and fleeing violence with addictions, and don't feel like they can call law enforcement because they're under the influence and they're on paper, they're on probation or parole, and need a safe place to say, help me get into a domestic violence shelter or find a trafficking program, and navigate then the criminal justice compliance issues so that they don't get warrants because they're going into a program, all the things. And so because I'm from that niche, I know how to interact with courts and the Board of Pardons and Parole and supervision agents and get them on board to support someone getting the help that they need so that they can get safe and then choose to get sober, right? Because someone being actively abused and trafficked, I'm not going to expect them to not be numb.
Right. That's their coping mechanism and how they're getting through each day.
Right. Right. Especially in trafficking, right? If you're being sold 10 Johns a day, I don't expect you to be sober.
Yeah.
So safety is first, right? Emotional, physical safety is first. So just understanding all of that, right? Giving people their autonomy back, letting them choose what is the next step for them, not shaming them, taking that blame and shame out of it and making it more of a holistic healthcare disease model of care, right?
Right. Yeah. Looking instead of shaming and pointing fingers or trying to have someone adopt some public standard for what it is to be a human. Really understanding that no matter what lens you look through, these are sick people that need help, and you can find compassion for a sick person like you would someone in your family who's going through something, that has a name that's recognized by the CDC as an actual disease. Find that level of empathy for someone who is struggling, and it sounds like you've really done that, and you've really embraced that community of people who are underserved and misunderstood. And I appreciate everything you're doing there. I think it's a fantastic model. Can you talk a little bit about some of the changes that would be extremely helpful in your industry? I think we talked a little bit about reimbursement rates for insurance, and they haven't changed in 10 or 20 years or something like that. Are you seeing that?
I deal with free models of care and Medicaid models of care right now.
Okay.
I'm dealing with the poorest, right? And the most abused, abject poverty.
Okay.
So for me, it's finding the peer groups. It's very difficult to find the dual diagnosis, mental health integrated into addiction models of care that aren't for the wealthiest, that aren't privatized. Most of everything Medicaid model is addiction over here and mental health over here, when really it's a pathways dual issue. Separating males and females in the inpatient side of treatment, because females have been such horrifically abused and exploited in the addiction space. They shouldn't have to do that level of treatment care with their abusers, with traffickers, with men that were in the trade that were using their bodies while they were addicted. It should be separate until aftercare. And getting them to separate is difficult as well. So you're not doing gender responsive care.
That's something I hadn't thought about. And there was
I've been a trafficked woman in an inpatient program where men are talking about using prostitutes in their addiction, and she's trafficked, and she should have to sit in that group and listen to that.
No, I mean, that's not a great way to get sober, healthy. No.
You're like, what? Yeah, aftercare, sober softball, the once a week, 1.0 care, aftercare groups, great. In-depth psychosocial, going through your biopsychosocial in your group with perpetrators.
No way.
No. No. And you have whole models of care, especially in the Medicaid space, that are addiction only, and they might have a trauma group once a week that you can choose to go to. So it's not integrated.
Mm-hmm.
It's not, adverse childhood experiences. The brain got rewired. The blood flow moved from the front of the brain to the back of the brain. You became limbic. You looked like ADD, ADHD in a classroom. Nobody saw it. You started acting out. You started getting criminalized, penalized. You dropped out.
Yeah.
It's not that integrated model of which came first, the chicken or the egg. The complex trauma rewired the brain. Then you needed to calm the nervous system. Alcohol did that. Opiates really did it. Or speed, if you have ADD, ADHD, soothed those systems. So it's not an integrated model of care unless you're paying private dollars for that level of care. And most of the people in the criminal justice system are not in that space. And so where are the dual diagnosis, mental health and addiction co-occurring spaces, right? That aren't just severely persistently mentally ill.
So, yeah, and you really just flipped a light switch on for me, because I personally, on my path, I went down that private route. I had access to all those services in a combined way with dual diagnosis, and it was magical for me. It was something that really helped. And
you could heal.
Yeah, exactly. Yeah. And there was a few people that were sent down through the criminal justice system that were involved there, but I would say the majority of them were on insurance, Cadillac insurance, healthcare plans. Mm-hmm.
Middle to upper class, didn't lose their housing, didn't lose their job, didn't lose their entire lives to addiction, right?
Yeah.
Aren't in that hamster wheel of poverty, lack, social determinants of health stuff, right? Like that people that intersect the way they normally do in the criminal justice system, poverty, racism, like all of it, class, addiction, mental illness, like all these intersections, right? Oppress you coming out in a whole holistic way, right? And the criminal justice system just layers a whole nother, fines, fees, community service, an agent telling you you're a piece of crap, threatening. It's not at all evidence-based. It's not strength-based. It's not culturally responsive. It's not gender responsive. It's not a holistic healthcare model. So then you've got that, right?
Yeah.
So helping people come out of that mire it takes years.
Mm-hmm.
It takes years because they go through the addiction piece and they get sober, but then they haven't dealt with the trauma. And so that internal engine is pumping that they want to get numb.
Yeah.
And heaven forbid they go back to the same relationships, the same poverty, the same lack.
Yeah.
Relapse becomes part of recovery if they jump right back into treatment. And it's most peer-led treatment in the Medicaid space, which is beautiful because there's so much empathy because they've been there.
Yeah.
There's so much understanding because they've been there. And then once they're well enough and safe enough, getting them into the good trauma-informed, somatic, responsive care so that they can get that blood flowing back to the frontal lobe again, think, calm, sleep, repair, calm the nervous system, so that they don't die 25 years early because of the trauma, right?
Yeah.
Because it's the cortisol and the dangerous chemicals running through your body that's aging your heart and your liver and your kidneys. So in my population, they get sober and they do well for a while, and then they die from cancer and ischemic heart disease because the trauma engine is still pumping.
Mm.
They're still living in poverty. They're still suffering and struggling and, really high suicide rates and really high, they haven't used in 5 or 6 years and they go back to use the same dose that they used before in the ODs, very high overdose death rates. And so those are the long-term health outcomes that we're trying to impact, right?
Yeah,
because
absolutely.
it's with education. You're sober now, when are you ready to do the next level of healing?
Mm-hmm.
And then eating healthier and understanding how food plays in to addiction, right? Sugar, people that are coming off opiates are craving sugar. They're eating as much sugar as they can. Same brain chemistry, right?
Yep.
Same brain chemistry. So
yeah, you got to get the dopamine, glutamate cycle rolling.
Yeah, but poor people don't get to learn about that kind of stuff in treatment.
Right.
So it's separate. So helping them understand like healthy foods and even changing it for themselves so they can change it for their children.
Yeah. Yeah.
Because if they have a high ACE score, their children have a high ACE score. If they've been addicted, that's an ACE. If they've been incarcerated, that's a second ACE for their child. If they've been estranged for their child for a period of time because of treatment incarceration, that's a third ACE. If their child was exposed to any violence while they were locked up, which, there's another ACE. The more ACE, the more adverse childhood experiences, the more likely they are to become dual diagnosis, end up in the criminal justice system and die 25 years early. So you heal so your children can heal.
Yeah.
So you don't leave a legacy of trauma and destruction behind you.
Yeah.
It's powerful.
It's absolutely powerful, and I think having someone to guide you through the physical, spiritual, and mental health aspects of recovery are they're essential, right? And if you only get
social determinants of health, so you have the addiction piece, and then you have the housing piece, and then you have the employment vocational training piece,
right,
and then you have the it's got to be holistic. It can't. And that's the other issue, right? Is most spaces are like, we're going to help you with addiction and maybe the mental health piece, and that's our silo. Right. And then there's this whole other system that's housing. And then there's this whole other system that's educational, vocational training, livable wage with a felony. Like, where can you work and live if you have a conviction, until it comes off in 7 years, if you get it expunged, where are the spaces? So that's where the holistic case management piece comes in, right? That's where we come in, is we understand how to work in the housing space, in the employment vocational training space, in the addiction mental health space, long-term, stay with you 2 years, 3 years, if you're severely persistently mentally ill forever, helping you manage all of this. But there's not a lot of funding for this kind of work.
No,
Even
I
though
was going to say,
prison, we save the state and the feds a lot of money.
Yeah, absolutely.
There's not a lot of money for this work.
Yeah. I was going to say, and when you talk about holistic and covering as much as you just mentioned, I can't imagine how you would get funding for that. I mean, it's just
holistic case management, right?
Yeah. Yeah, it's tough. And especially when, reimbursement programs and agencies look at these things as individual things, right? And you got a ton of paperwork and everything that's associated with each one of these different things. And then they're expecting the person who is being cared for to understand how to do all of that and, work their way through it. It's almost impossible.
It really is a mountain for somebody that's disabled to climb, right? Yeah. And with an addiction. And a lot of my women have children in tow. Yeah. So that increases the poverty and the stress and all of it. So how do you do it without support? You really can't.
You really can't. It's nearly impossible, I'd say. Crazy. Before we get too far into the call, I wanted to just spend a minute and talk about, someone who maybe is recognizing, hey, I really need help. And if they're in Utah, great if they can reach out to you. But, for folks that are outside of Utah, maybe not in your space, what are some ways that they can go get started and find some help? If they're finally ready to reach out and say, I just can't do this anymore. I need someone.
Yeah. I mean, I think a lot of people are just Googling, but 211 is in most states, and that's a good place to start. That's where all the county funded, state funded initiatory groups and programs and evaluations are when you don't have, especially when you don't have that higher level of insurance. Let me call my insurance provider and see which programs are available to me. Right. And there are peer level support groups that are free, and family supports that are free. 988, the new mental health line, has links to all these free groups. And then you can dig down into those groups, right? So there's addiction, there's depression, there's bipolar disorder, and then you can go into female only or LGBTQIA or Native American or veteran and be in a specific group. And then there's referrals in that service setting as well. And so I think, you know, most people are attached to a device, even the poorest.
Yeah.
And I think most people are starting with a Google search, for good or bad.
Yeah.
They're Googling their symptoms even and self-diagnosing. Like just about everyone is attached to a device that's telling them where the next steps are, right? Yeah. And so if there can be spaces that have good information, right? I think 988 is a great space because it's mental health focused first, addiction as part of the mental health piece. So it's that dual diagnosis focus.
Yeah.
But 211 through United Way in most states has addiction and mental health, right? And so the city, the county, the state level of intro into those spaces where the resources are.
Great.
Especially for the poorest.
Yeah.
211, I mean, 211 for housing, 211 for homelessness, 211 for food. Where can I pick up food right now? Like, you can pretty much find anything on 211.
That's great.
988 is that umbrella mental health resource.
Okay. Yeah. So 211, 988, and looking for local groups through Google. You know, those are great options.
Yeah.
Thank you. I know when I was starting my journey, I had no idea about these resources that were available. You know, I reached out to try to find a psychiatrist and was put on a wait list that was, I don't know, 4 to 6 months long. And I'm like, I need help now.
So were you Googling to try and find, were you researching that way?
I was looking through my my healthcare provider or my insurance provider.
Insurance, right? Because you have good insurance. Yeah.
I had good insurance, but you know, it did not do me well because it pointed me to psychiatrists that have no availability.
Right. Yeah. Right. Instead of social workers and community support.
Yes, exactly.
Right.
Yeah.
So you were waiting to get into a program and then, you know, or with a psychiatrist. Most poor people never get to see a psychiatrist.
Yeah. Well, I would say that my experience was very underwhelming. A psychiatrist, I had an idea of what a psychiatrist was, but it turned out to be someone who just looked at the forms I filled in and recommended a couple medications.
Yeah, it's med management. It's psychiatry is med management.
Yeah. And so that was not the help I was looking for. It's great to have medication. It helps me a ton. But the first part was really about like, hey, I'm struggling mentally. I need to talk to people. I need to start to understand the issues that I'm having and the problems that I'm having and how to actually get to, you know, some sort of solution.
Yeah, of course.
Yeah. All right. Well, is there anything, you know, top of mind that's really working well for your patients from a therapeutic perspective? You know, there's a lot of terms that people hear: CBT, DBT, you know, group talk, group therapy, you know.
Top down, bottom up. Yeah, top down is you know, a lot of that talk therapy, which can be extremely painful. It's got its utility, right? It's been around for hundreds of years. But what they're finding is the remission of actual symptoms is more bottom up, somatic body work, because the body keeps the score. I don't know if you've read Vanderkolk's book, The Body Keeps the Score. It's pretty powerful recognition of the duality of trauma and brain changes, adverse childhood experiences, and addiction, and mental illness and interventions, right? So the first part of the book is all about how PTSD was first diagnosed and wars and veterans, and then they realized children had the same symptoms as veterans. And the rewiring of the brain was about trauma, not just going to war. And how psychiatry changed around that, psychology changed around that, to today, where you have hundreds of brain healing interventions that can actually heal the brain, right?
Yeah.
So somatic dance and EMDR thought field therapy, eye movement desensitization reprogramming, and meditation, transcendental meditation, right? TM has some beautiful benefits, but there's free versions of meditations, right, online that people can use to start to unwire the brain, right?
Yeah.
To take the blood flow from the limbic brain back to the front of the brain so that you can sleep at night and heal and remember and function the way you were meant to function on this earth, right?
Right.
So the whole back of that book is about all of the new somatic body healing interventions, right? And then if you want to look even further now, there are, ketamine, there are faster ways to heal the brain, right?
Yeah.
And to get the neural networks connecting again. But again, access to that is for the wealthy.
Yeah.
I did ketamine. I did 5 ketamine sessions after doing EMDR for 20 years, and way more powerful jumps in brain healing. Yeah. And neural networks coming back together, and deep healing at a cellular level, right? So, and they're using it with veterans. The VA administration is using it. So if you're a veteran, you're going to get access, but otherwise you need private insurance to do that kind of brain healing work, right?
Yeah. Yeah.
Ibogaine and that kind of stuff.
Yeah, I've seen lately in the news that some of that is gaining traction and getting some support from the government. So I think that's great.
There's huge healing benefits from healing the brain faster, right?
Yeah.
Heal the brain faster. You can talk about it until it doesn't hurt anymore for 100 years.
Right.
And you still feel this, you can still feel your stomach churning, or you can heal the brain faster. There's faster ways to heal the brain. So, and trauma is inflammation in the brain. So reducing the inflammation in your brain is going to remit, Alzheimer's, dementia, things that are going to harm your brain down the road.
Yeah.
Further. So it's important to do that healing, that brain limbic healing piece. But most poor people don't get access to that. And so even helping them understand, okay, let's get you through voc rehab to get you access to that. Let's get federal money through the states to get that kind of healing accessible to you, because you're not going to get it in your Medicaid insurance, right? But you need that level of healing. So advocating for people to be able to do that trauma responsive somatic care for their bodies.
Yeah. For the people that need it the most, right?
Yeah, the poorest.
Yeah,
the poorest.
All right. Well, let's kind of switch gears a little bit. As I mentioned to you, I think before, I do work in systems automation. I've done that for 25 years in the corporate space. I'm moving into working with small and medium-sized businesses, because making billions of dollars for huge companies is okay, but if I can help someone like you make a difference in your community through automating business processes so that you can help more people rather than dealing with systems issues and those sorts of challenges, that's kind of what I want to do to give back to the mental health care community. So I wonder if you could just talk a little bit about technology in your business, not necessarily as a therapeutic resource or anything like that, but more about how you operate as a business, and then just some of your thoughts on AI as well.
Right. Yeah. I mean, we use all the Google Enterprise automations, the phone automations. We don't have to call and listen to our voicemails. We get an email and it says, what the person needs and needs help with, and we can kind of triage them from there. We have a CRM that we use that's HIPAA protected, that we can track all of the micro changes in somebody's life so that we can measure the outcome changes from homelessness to house to employed to completing treatment to completing criminal justice compliance requirements to all the things, right?
Yeah.
That show the social determinants of health are improving. Their income is improving and their housing stability is improved and their employment is improved and they're accessing, you know, all of the healthcare, medical care, dental care, all of the spaces that mean something to longevity and overall health.
Chris, quick question on that one. Do you have caseworkers that are filling in those details as they're meeting with clients, or do clients have access to forms that they fill in and kind of?
You know, it would be nice if there, you know, was an automated system that just went out every 3 to 6 months. Can you update us so that we didn't have to?
Yeah.
Because we've worked with over 5,000 women in the last 12 years. We can't contact 5,000 women, but if there was an automation that asked those 5,000 women, you know, can you update us on where you were, the quantitative pieces, right? Income changes, housing and all, but also the qualitative changes. Like, do you feel safer? Do you feel healthier? Do you feel supported? You know, do you feel like you could come back to us if you needed to, or have you tried and we were overwhelmed and you're on a wait list, right? Like we have hundreds of people on a wait list right now trying to get access to us because we're triaging the domestic violence, sexual assault, and human trafficking victims, and they take priority, right? Because they could be killed. And so, you know, getting to someone who just needs help navigating a system will be a minute. And so that's the other issue, right? Is once people say, oh, call Journey of Hope, it's that we're bombarded, and how do we triage all those people, right? And so is there a system that could be in place, maybe utilizing AI that helps people navigate these systems and helps them understand how to navigate the systems without us walking every single person through every single system? But we have the knowledge, we have the institutional knowledge, and we know how to do that. But then could we help more people that are waiting for us and suffering? With AI automations and online supports in an app, and more than a 211 list where they have to figure out the list. Do I fit into this group? Do I fit into this group? Because you're on 211, you're having to call every, do I fit here? Do I fit here? Do I fit here? And it's siloed. So housing, employment, occasional training, food.
Start over with each one, right?
Right. So I think there's a space to create a better 211 system that's trauma informed and responsive and health centered, and to help people navigate until they can get with a one-on-one person, right? Or talk in a group setting, and somebody after group says, I navigated that, this is how I did it, right? So I know there's better ways to do this.
I spoke with a founder yesterday that works in the military space and with the VA, and he has a project called Alana AI that is looking at this for the military space. And so, I think it's a fantastic idea. You know, I think he quoted that the VA is 40,000 mental health care providers short right now. Right. And I think that you're seeing the same sort of gap all over the place. Like, there's just not enough people out there to help. And so how do we solve for that? You know, we hopefully integrate some of this great new technology with artificial intelligence to at least start helping people, like having people find a path to getting help and eventually working with a person to deal with some of those issues. And so,
and I think people want to support veterans. Like, they're like, they chose to serve our country. We deserve to make sure that they're healthy when they come home. People don't always feel that way about homeless.
Absolutely. Yeah, no, there's
somebody walking out of prison or jail, but they look pretty similar other than the service in the military as far as the trauma And you shouldn't
Yeah.
have to tell people's whole story. Like, don't judge her coming out of prison and losing her child. She was trafficked from age 3 until she went to prison.
Yeah.
Like, but you shouldn't have to. And then they go, oh my gosh. Oh yeah.
Yeah. Now I care. Yeah.
Yeah. Now I get it. Now she's worthy.
Yeah. Yeah. So yeah, the stigma cloud is just, raining on those folks. And yeah, it's tough. So yeah, I think, everything you mentioned about, having access to some tools that automatically go out to, your, folks that have been through your program and getting updates and like all of that is something that's very doable with the tools we have today. Would love to work with you on that. And then I think the last time we spoke, you talked about, you have so much knowledge about just the way that life goes for these folks, starting from an early age and, identifying these patterns and finding these people while they're on this journey and hopefully helping them find a different path, as well as dealing with folks that have been through the ringer and they're at their last hope, right? And building some sort of an app that's available to them to help them out, I think is something that's an amazing it's an amazing thing to think through. And when you speak about the patterns, my mind is building workflow diagrams about how we could actually build a system.
We can interrupt it.
Exactly.
And it
right.
can be interrupted for their children, right? Like,
yeah,
that's the power, right? Is their children don't have to go through these same patterns and suffer and end up in the criminal justice system and die 25 years early. Yeah. Like their brains can heal faster. Children, when we skin our knees, when we're little kids, we get up, we wash it off and the scabs are gone. When we skin our knees now, we limp for like 6 months because we don't heal the way we healed as children. Children's brains can heal so much quicker than an adult brain. It's ingrained. The pathways are ingrained, right? By the time we're in our 30s, 40s, 50s. But children who are experiencing trauma can heal, right? You can stop the inflammation. In fact, I was talking to someone who had worked with Vincent Folletti, who did the ACE research initially, right? 25, 30 years ago. And he said, it's all inflammation. If a child is having a traumatic experience, someone's driving their parents away and arresting them. Yeah. Why not give them an ibuprofen to stop the inflammation? You'll stop the rewiring of the brain. And my brain just kind of exploded. Like I was like, oh, we don't need to do EMDR and thought field therapy and talk and all these things. No, stop the rewiring of the brain in the moment. Stop the inflammation that's occurring in the body in the moment of trauma. And the brain will not be rewired, right? The blood flow will stay in the front of the brain. They'll be able to listen the next day in school, maybe not as good, but the blood flow will still be flowing up here and not have gone back to fight, flight, and freeze, right?
Yeah.
So just all of that knowledge, right? All of that trauma-informed, trauma-responsive knowledge, we can intervene at any point when someone's showing up in those spaces, right?
Yeah.
In schools and in pediatrics and in hospitals. So I see the app maybe paid for by the programs that need to help these people and social workers and do-gooders and peers, and free for those that are suffering, right? In addiction and illness.
Yeah. Well, that's great. I definitely want to spend more time with you talking about that. I want to just sort of better understand how we could maybe partner together on something like that and get that started. And I'm sure that there are a number of people that have been through experiences that would love to chip in and help out with this sort of thing as well. So,
awesome.
I'll look to set up some time with you and maybe we can work together on that.
Beautiful.
Okay.
Perfect. Thank you.
Great. Thank you very much. I have a quick question for you before we close. I just kind of want to give you an opportunity to just kind of speak to someone who's maybe just getting started in mental health care. They're recognizing that they have an issue and need to do something about it. What's your, sort of elevator pitch about, getting started in mental health care?
Yeah, we weren't sent to this earth to suffer and die. We were sent here to heal.
Yeah.
And you're just on a journey. And every experience, for good or bad, is just a lesson if you'll allow it to be. If you'll color in the picture with hope and love instead of, fear and shame. Every situation is a lesson. So learn and change and grow, because that's why we were sent here. And then once you do that, pay it forward.
That's perfect. That's beautiful. Beautifully said, touching. Thank you so much. I love your passion for helping underserved folks. And wow, Shannon, I really look forward to talking to you again.
Thank you. Thank you.
All right. Thank you so much.
Have a blessed day.
You too. Bye.
All right.